on this platform today. The support from IUA has really been important in organizing this program. So thank you to Indian Optometric Association being the partner for this session today. Let me have privilege to welcome all the participants, all the guest speakers, seniors like Amod sir. It's really good to have him on this platform. For me, if you ask me about the orthoptics, from last 22 years, I've been just doing that work. I've been enjoying, in fact, doing that work. And very confidently, I can say in strabismus, nothing moves without good orthoptics, good pediatric refraction, and good dispensing. And that's where the role for an optometrist becomes really important in managing these strabismic cases. Many times, actually, we are not very confident, or in fact, we're not really happy when we happen to see the patients landing up into a clinic and complaining about the double vision problem or some abnormal head postures. Or even the small children, particularly the infantile kind of esotropias. So that's where we are going to have the speakers today with us. We have Anton. I know him personally. He's really a lovely guy to interact with and vast knowledge about the subject. So we will be learning from him about the tips, how we as the optometrists in our routine practice, without requiring the fancy equipments, can really reach the diagnosis. Whenever we happen to see this patient with the double vision or the paralytic strabismus, we feel challenging because many times we are not very clear about the basics. I call this paralytic strabismus as completely as a maths. It's so interlinked with each other. If those basics and concepts are clear, then reaching to that final diagnosis becomes really interesting, and really you feel proud in doing the kind of job you does for your patients. So that's what I'm expecting from Anton to help us in learning those tips to understand the cyclovertical muscles, which is the muscle which is affecting, which is making the patient to have that double vision problem or abnormal head postures. And then today we have with us Johanna. I have had a session earlier with her. She's really good in her subject. So she'll be talking about the infantile esotropia. In our squint clinic, if you ask me, we operate a lot of infantile esotropias. I call infantile esotropia not just a strabismus, it's more as a syndrome. It's not just a deviation in the eye. In fact, it comes with many other problems like DBD, nystagmus. We have a dampening of nystagmus blockage syndrome. And operating those patients, I think the easiest thing is to operate those patients. But these patients have multiple surgeries. One surgery is not sufficient. To have a complete management plan for these patients and to explain them how the journey of management plan is going to be, and in to have a close follow-up, playing with those glasses, over corrections, under corrections. So try to give them that sensory vision development, sensory functions development, if it's possible, if you can get the patient right in time. So that's going to be the focus from Johanna in her talk today to help us in understanding our basic concepts about it and how we can help these kind of patients. And then we have a small talk from our partner today, IUA, Rajiv, Secretary of Indian Optometry Association, will be giving the update from IUA, how the optometry doing in India after this act, which is there now on regulation of the optometry and other paramedical programs in the country. And in fact, I saw a notification yesterday that the commission is formed. So we can see more updates from them and what our future path is going to be. That's where the Rajiv can help us in getting more updates from that area. And finally, I'll be having my talk on managing these patients with the double vision problem, how the prisms can help, and simultaneously, how can you help your patients in gradually weaning off those prisms with the help of Vergence exercises and making them develop these sensory functions back. So that's how the session is going to be. Thank you, everyone, once again. And I'll now request Dr. Bita to moderate the session and start with our first speaker. Thank you.
Thank you, Mr. Prem, and hello everyone for joining us today for today's symposium. And before starting the session, I would like to request you to please take part in a poll which we are conducting today. The question will pop up on the screen and you can just answer them. And also, in order to get the certificate from today's session, you should, the question is already there. You should just provide us the correct name, please. Well, today we have Mr. Anton de Cruz Wanba, if I'm just pronouncing his name correctly. He was a faculty optometrist in retina department at LV Prasad Eye Institute as well as in Shankar Netralaya in Chennai. He has been teaching almost all the subject in optometry curriculum from eye anatomy to contact lens and binocular vision. He have mentored over 100 research projects as well. Currently, he is the educator and the practitioner at Bansara Eye Care Center in Shillong. Today, he's going to talk about the paralytic strabismus key to evaluate. Mr. Anton, I would like to have you in screen.
Yes, thank you.
Yeah.
Good morning to some of you, good afternoon to some of you, and good evening to some of you. It's such a pleasure and a joy to be here this particular day. I would like to thank Prem and Dr. Bita for the wonderful introduction. I would also like to welcome our other speakers, and I would also like to wish them all the best in their presentation. And I hope that all of us will go back with the knowledge and the concepts that we gain today in our presentation. Okay, so today,
Sorry, Beta, we are not able to hear you. You're on mute.
Anton, I think you are supposed to be sharing your slides. Could you do that?
Oh, your screen is not been shared yet.
Yeah, I can't see Anton. Anton, can you hear me? He's not there in the list, I think.
Oh yeah, probably he should join again.
Abhishek, if you can connect him, do you have his contact number?
Okay, I will just contact our
Anton is
IT
there.
team.
I could see, I could see he's there. He's there. Anton, can you share your slide? Any issues with that? Can't see your slide. Can't hear you. Can't hear you.
can you all hear me now?
Yeah, now I can hear you.
Yes.
Now we can hear
Okay. Okay, sorry,
Yeah.
let me just share my screen.
Yeah, your slide is there. Your slide is there.
Okay, now, sorry about the technical problem. As Prem was saying, paralytic squint is a squint that really gives us the nerves and it helps us to doubt our knowledge and our skills. But over the years, as you see more and more patients and as you practice more and more, you become comfortable and it becomes easy for you to tackle these cases, and it also helps you come to a conclusion or a diagnosis where you'll be able to advise your patients. Now, I've divided my talk into various parts. I will introduce the topic. It's very simple. I will talk about the general features that are also very simple. Then I will go through various clinical evaluation techniques that are again very simple. Now, as Prem has emphasized, the clinical techniques that I will talk about that I will talk about today are the techniques that you can actually do in your own practice. You don't need any fancy equipment. Okay. And a majority of my slides, someone should mute their mic or speaker, please. And the majority of my slides and the knowledge I'm going to share today is based from Von Nuden. Now, Von Nuden is a book that most all of us know, and those of us who have actually studied binocular vision, we've got all our foundational knowledge from Von Nuden. Now, at the very outset, we cannot diagnose squint or any type of strabismus without the edge test. Now, the edge test is a very important test for us. Okay, so all of you know what the edge test is. All of you know where the muscles are marked in the edge test. Now, just a brief outline, the innervation of the extraocular muscles are from the three cranial nerves. That's your LR6. That means your lateral rectus is supplied by the sixth nerve. SO4, the superior oblique is supplied by the fourth nerve. That's your trochlear nerve. Whereas the rest are supplied by your oculomotor nerve. That's your third cranial nerve. Now, the other thing that you should keep in mind are the obliques. Now, the obliques together with the recti. Now, for example, a simple mnemonic. All superiors are intorters. That means your superior rectus and your superior oblique, they intort. And all inferiors are your extorters. That means your inferior oblique and inferior rectus, they extort the eye. So if you get this concept right, everything else will be easy. Everything else will be quick and simple for you. All right. So your superiors are intorters, your inferiors are your extorters. Okay. Now, a brief look at the various terms that we use in paralytic strabismus. Paresis. Paresis is one, and paralysis. Paresis, generally the term means incomplete, or in our line of work, incomplete loss of function. That means there is some function remaining and there is some function also lost. Paralysis, on the other hand, would mean complete loss of function. Right? Now, why do these two happen? Why do paresis happen, or why do paralysis happen? They happen because there's a motor imbalance. Why is there a motor imbalance? Because either one extraocular muscle or a group of extraocular muscles have either partially lost their function or completely lost their function. Okay, so these two terms, please make sure you don't interchange them because they mean quite different things. Paresis, incomplete loss, and paralysis, complete loss of function. Now, before we move on, you have to keep in mind, it's very important, you have to keep in mind the basic differences between a paralytic squint and a non-paralytic squint. It's important for you to identify based on the type of onset. If the squint has a sudden onset, it's clearly a paralytic squint. If a squint occurs at any age, if there's a head trauma is always one of the main causes of paralytic squint. Someone who had a road traffic accident, most commonly people who fall from motorcycles. People who fall from motorcycles when they hit their head on the road, very unfortunately, they somehow 40 to 50% of them end up having paralytic squint. They end up having paralytic squint. Diplopia is sudden. Now, diplopia is never present in non-paralytic squint. As you all know, binocular vision has one key component known as suppression. So suppression eliminates amblyopia in non-paralytic squint. But in paralytic squint, we have bypassed the grades of breakdown, hence you have diplopia. Now, amblyopia is absent in paralytic squint. Amblyopia is present in the other types of squint. Comitance is uncommon. That means the squint measure or the squint values are not equal in all the 9 positions of gaze, whereas in the other squint, they're equal. Head posture. Head posture is abnormal. Now, let me show you. Uh, this is a face turn, and this is a tilt. So people can have face turns, and people can have tilt, and people can have chin up and chin down. They mean different things. By the abnormal head posture, you can correctly guess with confidence the muscle that is affected. I will come to that in a bit. Now, sometimes maybe 20 to 30% people who have associated systemic diseases end up having paralytic squint. It's very unfortunate, but they do end up. Now, what are the stages of paralytic squint? There are 3 stages in paralytic squint. The first stage is there's weakness of the paralyzed muscle, which results in the overaction of the antagonist by the various laws of innervation, the Hering's law, Scheringer's law. The second stage is there's overaction of the antagonist or the paralyzed muscle. And the third stage is, remember what I told you in the last slide, all paralytic squint are concomitant. That means they have unequal values of squint in all the 9 positions of gaze. But long-standing paralytic squint eventually become comitant. And the squint spreads to the 9 positions of gaze. Okay. Now, moving on. What are the history points that you have to keep in mind? Remember, in the medical field, in the optometry field, or in any medical field, a good history is 80% of the diagnosis. A good history. If you slip short your history, that means if you take shortcuts in your history, you will never be able to come to a 100% diagnosis or a conclusive diagnosis. The first history is whether the paralysis is acquired. What do I mean by acquired? It means the paralysis is of recent origin. Okay, if the paralysis is of recent origin, it is an indicator that the patient has poor general health. The general health of the patient is poor. Second, there is restricted movement in the field of action of the paralyzed muscle. Okay. Third, diplopia is very common. I'm actually repeating slightly the previous 2 slides that I had just talked about. Next, there's increasing deviation. Now, this is the, how should I say, the crucial point. When you do your UCT and when the normal eye is fixating, when you measure the deviation would be, let's say, of 10 prisms. But when the squint eye is fixating and you measure the deviation on the normal eye, the deviation on the normal eye will always be more. So there is increased deviation when you fixate with the paralyzed eye, right? And you always have most common your compensatory head posture. Compensatory, why? Easy. Our visual system deplores diplopia. That means our visual system hates diplopia. So how does the visual system enables us to counteract diplopia? You tilt your head. The moment you tilt your head, you kind of like bring about fusion. And also your obliques, they have their own set of cyclofusion. So both these fusions, they work together and they maintain single binocular vision. Very important, right? I'll move on. Now again, history. I'm still stressing on history because I believe a good history taking is the crux of medical science. Time of onset. When did it happen, right? It may be long-standing. It may be recent onset, okay? This tells you what is their status of their general health. For example, a patient who has an uncontrolled diabetes or uncontrolled metabolic disorders, invariably they end up having 6 nerve palsy. We all know what 6 nerve palsy, and we all know how often people with poor general health end up having 6 nerve palsy. Head trauma, double vision, diplopia. You have to observe. Observation of the head posture gives you an indication of the weak muscle. right? Now we begin with clinical evaluation. Very simple. There's nothing towards it. Now, all of us know how to do a normal comprehensive optometric or an ophthalmological workup, right? Now, our workup is important. All of this workup is before you dilate. Squint evaluation is never done after dilatation. If someone tells you that I've done a squint eval after dilatation, that means they have little knowledge of squint. Yes, there are certain things we do after dilatation, but a majority of the evaluation happens pre-dilatation or pre-cycloplegics, right? Then you've got the edge test. I've told you the edge test is very important. Then you've got your ductions and versions. For those of you who are confused, ductions is the uniocular edge test where you occlude one eye and you perform the edge test with just one eye open. Version is the binocular edge test. Then you measure the deviation. Remember in the last two slides, I told you the deviation with the squint eye fixating is larger. The primary deviation. Now, there are two kinds of deviation. Primary deviation is when you fixate with a normal eye and you measure the squint on the squint eye. Secondary deviation, on the other hand, is you fixate with the squint eye and then you measure the squint on the normal eye. You will always see that the secondary deviation is always larger than the primary deviation. This is the crucial or the game changer. You see this, it's a sure shot diagnosis of a paralytic squint. All right, people? Now, these are a few examples I've taken from Von Newton book to give you a brief understanding of secondary deviation. Now I'm using my mouse. If you look here at the primary position, you will see that both the eyes have certain amount of squint, but in this case, the left eye would be the squint eye and the right eye would be the normal eye. So if the left eye is fixating, you will see here the left eye is fixating, the right eye will shoot up, and vice versa. This is again another example, right? Especially when the left eye is fixating. Here, left eye is fixating, the right eye shoots up. This is secondary deviation, meaning the deviation of the normal eye when the squint eye is fixating. Okay, moving on, people. Now, diplopia field charting is something that we start off when we want to evaluate a paralytic squint. It's very simple. It does not consume time. It's very easy for the patients to understand, and it gives you a fair idea of what is happening where. Right. So before starting, you have to use a red-green glass or goggles, and then you use a pen torch, and based on the patient response, you plot the graph. Right. So I've given you a few examples here about red-green goggles, the reaction. Now, just to remind, I'll move forward and I'll come back to this graph, to this picture. Now, if there's no separation, that means there's no diplopia. If there's separation, that means there is diplopia. Now, the separation tells you the field of action of the paralyzed muscle. Now, if there's a horizontal separation, and it's uncrossed, that means either lights have not crossed to the other side, it tells you it's esodiation. If there's a horizontal separation and it's crossed, it's an exodeviation. If there's a vertical deviation and it's uncrossed, it's mostly an oblique muscle. If there's a vertical separation, it's crossed, it's a vertical recti muscle. Now, if you look at the graphs or the pictures I've kept here, this is pretty straightforward, right? It's uncrossed. Here, the red has crossed, right? So this is purely an exo. As you can see, right middle rectus under action. So if there's a middle rectus under action, the lateral rectus will overact, giving rise to an exo. Okay. Then here you've got the vertical, right? See, if you can see in the vertical area, the red has crossed. So it's a vertical recti muscles. It's a vertical recti muscle. Here, if you see, the red has not crossed, right? So it's not crossed. It's an oblique muscle, Okay, so on and so forth. Now, as a rule of thumb, keep in mind this box. Very simple to remember, right? Very simple to remember. If one color, if one color stays stationary or stable, that means that color eye is normal. And the color that keeps on shifting here and there, that's the eye that has the paretic muscle. If it's uncrossed, that means if the colors do not cross each other, okay, it's esodeviation. If it's crossed, it's exodeviation. In the vertical sphere, if it's uncrossed, it's oblique muscle involvement. And if it's crossed, it's vertical recti muscle involvement. Okay, moving on. Now the Hess chart. The Hess chart is actually a very precise measurement of paretic muscle. This requires some understanding from the patient and some patience from the patient to be able to pull off the Hess chart. But once you've done the Hess chart, you can clearly quantify, you can actually quantify the amount of paresis or paralysis a muscle or a group of muscles has. Okay. Now the Hess chart is based on the principle of confusion. You determine the paretic muscle. You use the test, or the test is done with only one eye fixating, right? It's usually done at 50 centimeters. The distance is very important. You please do not do the Hess chart when the distance is closer or further away, because you lose the purpose of the test. Again, we have to use red-green glasses. Why? Because red-green glasses, they break down the fusion. Now, first, always red, right, RR. First, the red glasses, the red goggles are kept in the right eye, and the patient is asked to place the green light, where the red light is illuminated on the chart. Okay. Once this is done in all the fields of gaze, then the red goggles are placed in the left eye. So when the red goggles are placed in the left eye, this is where you test for the right eye. Now, I'll repeat again. The red goggles are first placed in the right eye. That means the red goggles are placed in the right eye. So the right eye is not tested here. The left eye is tested. Why? Because the green light, the patient will see the green light, and the patient has to coincide the green light with the red light on the chart. Okay, so you have to move the red light in an H pattern so that patient can coincide the green light. Once the right eye is done, then you put the red goggles on the left eye, and now the right eye is being tested. In the end, when you draw the Hess chart, the diagram will look something like this. Now, if you ask me why are there two boxes here, don't be confused. Now, when you start with the Hess chart, there are areas where they've already marked. So always start with A, B, C. There'll be certain areas, where they start with A, B, C, D, E, F. So you follow alphabetically or in alphabetical order, and the patient will mark with the green light where the red light is shown on the Hess chart, right? Now this takes some time, but once the patient is used to it, it's very accurate. Okay, moving on. Now the other test that we all use in the clinic from time to time is the Maddox rod. Now Maddox rod helps us to diagnose cross and uncrossed diplopia. The Maddox double rod test helps us to diagnose cyclodeviations. That means deviation related to our oblique muscles. Now it's called a Maddox double rod because it uses two Maddox rod. Now this is a method where you quantitatively, that means you give a value to the cyclodeviation. The red, again, RR, red Maddox rod is kept in the right eye. The white Maddox rod is kept in the left eye. Now these Maddox rods are aligned 90 degrees, meaning vertically. A pen light or a pen torch is shown on the patient, and the patient will tell you that the patient will see horizontal streaks. Now, for example, this is what the patient will see. Suppose the patient sees this slightly deviated red line. deviated to the nose, right? Now, if the patient sees this, example, patient sees red line slanted towards the nose. This suggests there is excyclotorsion, or that means there's an extorsion in the right eye. So you turn the Maddox rod, here, X cyclo, turn, till the point the two lines are parallel. So if you read off the trial frame, you will see that the Maddox rod has been turned to 100 degrees. This gives you an idea that there is a 10 degree of excyclotorsion. There's a 10 degree of excyclotorsion, right? Now, why do we need this? We need this if you suspect there is a cyclodeviation. Why? Because cyclofusion, remember, I had mentioned it earlier, you have fusion for normal binocular vision, and there's also cyclofusion where the oblique muscles themselves fuse to avoid diplopia. So when you do the Maddox rod, you break the cyclofusion and you bring out the cyclodeviation that's inherent. Now, the three-step test. This is one of the most common tests that we do in the clinic, right? The first step is in cover test, which eye has a more vertical deviation. The second step, the vertical deviation is greater where? Right or left gaze. Third step, you have the Belskovsky head tilt. The vertical deviation is greater where? Right head tilt or left head tilt, right? This is actually a classic test, but it has never failed. Now, for example, if there's a right hypertropia, that means the right eye has weak depressors, or there's a weak elevator in the left eye. So you circle. The second step, let's say there's deviation in the left gaze. So you circle your left gaze muscles. And the third step, the Belskovsky head tilt. For example, here in the right head tilt, there's a greater vertical deviation. So when you tilt your head to the right, your right eye will intort and your left eye will extort. So the right eye, the intorters are your superior rectus and superior oblique, and the left eye will be your inferior oblique and inferior rectus. So in this case, the right superior oblique is the weak paretic muscle. Okay. Now, this has never failed, right? It has never failed. So this is one of the most accurate tests where you can pick out the weak muscle. But mind you, only when you have vertical deviation and only when there is a paralytic squint. The Park 3-step test is not used when there is not a paralytic squint. Now, head posture. Head posture is something that happens to our visual system. It's involuntary. Head posture is involuntary. You cannot control your head posture. Why? Because head posture is inherent in the avoidance of diplopia. You want to avoid diplopia, you have to have head posture. So our central nervous system innervates the neck muscle, right, to have a head posture to eliminate diplopia. If there's a head turn, suppose I'm turning my head to the left. If I'm turning my head to the left, that means I'm turning my head to the side of the weak horizontal muscle. If there's a head turn, that means the weak muscle are your horizontal muscles. Easy. If I'm having a head turn to the left, that means one of my horizontal muscle in the left eye is weak, either the lateral rectus, most probably, or the medial rectus. If I'm having a head tilt, if I'm having a head tilt to the left, that means the muscle in my right eye is the weak muscle. It's easy. A head tilt will always point to the opposite oblique muscle. If I'm tilting my head to the left, my right oblique, one of the obliques in my right is weak. If I'm tilting my head to the right, one of my obliques in my left would be weak. Right? So this is very simple. Head posture to avoid diplopia, head turn to the left or to the right. Head turn in that direction will give you a clue that if it's a left head turn, the left horizontal muscles are weak, either lateral or medial. And head tilt, if the head tilt is left, the right obliques are weak. Always head tilt points to the opposite oblique muscle. Now, I have touched upon the various cranial nerves because cranial nerves palsy are again paralytic squint. Now, third cranial nerve, it's very common in this case of the child, okay, with the left cranial nerve. right? Then you've got your fourth nerve palsy. Fourth nerve palsy will touch on your superior oblique, right? In this case, again, the right eye. And your sixth nerve palsy. Sixth nerve palsy will touch upon your lateral rectus. In this case, again, the right eye. Okay. Now, what are the treatment and the referral pattern? Now, what's important is our treatment aim is to prevent diplopia. That's very simple. We aim to prevent diplopia. Number two, we use prisms, which Prem will talk about if it corrects diplopia, right? We use, and there are many different types of prisms. I'm sure Prem will talk about it. Then if it's of a neurological cause, now remember, your third nerve, fourth nerve, and sixth nerve palsies are neurological causes, right? They are neurological causes, right? You have to advise a CT scan. It's important for you to understand a CT scan is used to rule out any growth or tissue in the brain or the visual pathway. An MRI is used to rule out. An MRI is used to rule out any vascular block or infarction in the brain or the visual pathway. In case both these scans come out positive, then you have to refer the patient to a neurologist or a medical specialist for consultation, right? And usually neurological squints, they usually resolve on their own if there are no underlying causes between 4 to 6 months. Surgery is indicated for long-standing diplopia, right? And surgery is again indicated for long-standing compensatory head posture. Okay. Now, finally, the talk that I gave today, it covered what is a paralytic squint. Why is it important to take a good medical history? It's important to do a comprehensive workup. The edge test is important. Diplopia charting is important. The Hess chart is important. The Maddox double rod test is important. Three-step test is important to actually rule out the obliques. And it's important when to send the patient for treatment, if you can, or referral to a higher center to manage neurological cases. Now, with this, I would like to end with this famous diagram from Greece. Now, even though in the 1500s, people had no clue about binocular vision, the painter of this diagram actually had the foresight to draw. If you look carefully to draw, it actually gives out all the binocular vision aspects of that particular building at that point in time. Thank you. I hope, Dr. Beta, I have not surpassed the time that you've kept for me.
Thank you so much, Anton. And
if anybody has any
in my college time, that Sat Imam was putting so much effort to just teach us all these subjects. And I strongly agree with you about the history. People who are having experience in orthoptics know what we are telling. History means simply let patient talk and also ask relevant question. I remember one day we were in very rush screening day, and I was asking my patient that, have you done any cataract surgery? And he said, I don't know, you tell me. I said, sorry, we are not fortune reader. If you tell me, I can just do your work faster. So thank you so much for your presentation. And if anybody has any question, please write in the chat box. So Mr. Anton is here to answer you, or you can just leave it at the end of session. So I just check if there is any question for you. Okay, so far no questions. So you are having still time till end of the session. So let me introduce the next speaker.
Thank you.
You're very welcome. Miss Joanna Arcatiu. Joanna is an orthoptics graduate from the University of Liverpool in 2019. Following clinical placement and graduation, she was immediately hired as an orthoptist at a private practice in Cyprus. Over the last year, Joanna has also taught medical students about visual development and ocular motility disorders. Her topic today is about surgical management methods for infantile esotropia. Joanna, very welcome. I just shared the screen with you. Are you there?
Hello,
Hi.
everyone. Thank you for the lovely introduction. It's an honor to be here in this symposium with everyone today. Let me just share my screen. So my talk today will be on the surgical management methods for infantile esotropia. And we know by now that the time of intervention for infantile esotropia has long been debated in the literature, but there is a lack of consensus regarding the optimal treatment method. The general management options include the correction of refractive error, the restoration of visual acuity if amblyopia is present, and surgical treatment. Now, the outcome measures of a surgical correction for infantile esotropia includes orthophoria, meaning that we need to have a postoperative deviation measuring 10 diopters or less, that we have a stable alignment over time, and sensory outcomes, which is the evidence of any binocular vision, which usually in this case is subnormal. Sensory outcomes are particularly important as deteriorated BSV has been shown to have a negative impact in children's motor skills, as well as limiting the range of occupations they can undertake in the future. Now, the complications of any strabismus surgery include over and under corrections, double visions, hematoma, slipped muscles, anterior segment ischemia, whether multiple muscles are being operated on, and endophthalmitis. And let's start with the most common and most traditional surgical management method, which are bimedial rectus muscle recessions. This involves the disinsertion of the medial recti of each eye and the reattachment at a predetermined point behind its insertion closer to the point of origin, as shown in the diagram here. This produces a slackening of the muscle fibers and weakening the muscle's action. The advantages of this technique include that it is a simple and symmetrical approach, that it involves a shorter operating time, and that it leaves the lateral rectus muscles untouched for consequent surgery if required, which is highly likely considering the profile that we have for infantile esotropia. And lastly, recessions are considered more predictable and effective than resections, as well as being reversible. We have a graph here summarizing the main studies that investigated the effectiveness of bimedial rectus recessions. We see that we have a mean treatment success rate of 57.3%, but what's most important to note is the larger range of success, which was between 17 to 91%, so a lot of contradiction in the literature. And we see that under corrections were about 3 times more likely than over corrections, especially considering that the median amount of recession in the literature was 6.9 millimeters. Now, in terms of stability postoperatively, ASAF reported poor stability overall, with only 14.7% of patients maintaining stability, and 64.7% shifting towards the minus side, meaning that the undercorrection decreased or they were overcorrected. And 20.6% had a shift towards the plus side, meaning that the undercorrection has increased or the residual esotropia was larger. This, depending on the residual deviation and the direction of the shift, could have a positive or a negative effect on the alignment. And it was shown on this study as well, where the rate of alignment had further increased by 10.7%. And overall, most authors report poor long-term stability with a really high incidence of consecutive exotropias, despite good initial success rates. And there's also papers regarding late onset consecutive exotropias, which are really important when discussing the management plan with the patient or with the family. And regarding the expectations post-operatively. The only author that reported good stability over a 3-year post-op period was Prieto Diaz, where the rates of stability not only remained stable, but improved by 1.4%. And in terms of sensory outcomes, the only authors that had any information on these were 1 and 2, where only 27% of patients had some evidence of any level of BSE at the final follow-up, with only 6.8% showing any evidence of stereoacuity, which included patients that were considered orthophoric, that needed retreatment, or had a deviation which was greater than 10 prism diopters, but did not require any further surgery. Stager et al. Also reported that patients that developed a consecutive exotropia postoperatively were no longer able to achieve any fusion or even engrossed stereopsis. And now moving on to 3 muscle surgery, which is compromised by biomedial rectus recessions with an additional contralateral lateral rectus resection. Some strabismologists prefer this method as it has been reported to have better undercorrection rates. However, the disadvantage of this technique is the fact that the contralateral lateral rectus is irreversibly resected, and therefore we have limited available surgical choices if subsequent surgery is required, which, as we have seen in clinical practice, is highly likely. And once again, we have a graph with the summary of the data collected from the literature. Fairly similar treatment success rates with an average of 57.7%. However, more reasonable range between 30 to 22.4. In this case, we had twice as many overcorrections at the first postoperative appointment than undercorrection. And this can be attributed to the fact that the median amount of recession was much larger in this group, which was 8.5 millimeters, compared to the 6.9 in the biomedial rectus resections group, with a combination of the lateral rectus resection. Now, in terms of stability, Hadjistefano et al. Reported an overall 17.7% reduction in treatment success, and they found a statistically significant increase of 90% in the rates of overcorrection. Again, we're seeing this pattern of later onset consecutive exotropia. The authors also found that the rates of the exotropic drift were 3 times more common compared to isotropic. And by this point, we only have 1 lateral rectus to work with, which is important to consider. And again, they assessed the mean times for the recurrence of isotropia compared to the development of consecutive exos, which was much later on compared to the residual iso. They also investigated any associated findings that had impact on the success rates, and they found that the presence of inferior oblique overactions, as well as the presence of significant and severe amblyopia preoperatively, to increase the chances of late under or late overcorrections. And now moving on to more recent methods, which include the botulinum toxin augmented surgery, which is once again the biomedial rectus recessions augmented by botulinum toxin A. Now, the advantages of this technique include that only 2 muscles are being operated on. Therefore, we're reducing anesthesia duration and the risk of surgical complications. And once again, the lateral recti are being preserved for additional surgery. Now, the disadvantages of this technique include that we have a lack of evidence concerning the dose-response impact of the botulinum toxin augmentation. We have no specific surgical dose tables for this technique, and we are unaware of the optimal botulinum toxin dosage. However, there are a few clinical trials that are underway now. We are hoping to give us more information on this technique. And additionally, we have the associated transient complications due to botulinum toxin leakage, which we'll discuss a bit later on. And here we have the collected data. As you can see, there's a lack of evidence regarding this technique as it's more recent. We have the best mean treatment success rate so far with a 66.3%. We can see that the over and under corrections were about similar, and that the median amount of recessions was the least so far of 6.3 millimeters, which can be beneficial in the case of any residual esotropia, whether we want to reoperate and re-recess the medial recti. Now, in terms of the transient complications, there's quite contradicting evidence on that as well. Warner Gilbert reported that all their patients in their small study had complications, with 86% of the patients having transient overcorrection and 50% of patients having a transient ptosis, which resolved within 3 months. But this can be quite concerning to the patients, therefore it is really important to be explained to them. On the other hand, Luder and Peccato report that only 6 out of the 72 patients had transient complications, with only 10% having transient ptosis post-operatively and 3% having a transient vertical deviation. And moving on to a different surgical methods, here we have the hangback bimedial rectus recessions, where essentially a loop, as shown in the diagram, is formed by the original insertion and the muscle, and the distance of the loop is the pre-calculated amount of recession. This technique had excellent success rates of 76.2%. Therefore, it is much more effective than the standard bimedial rectus recessions. This technique also has a reduced risk of scleral perforation, as the needles are entered into the tendon stem instead to the scleral attachment. Even though the risk is quite small, it's better to still avoid it. Authors report that this technique also allows for more recession to be done compared to the standard bimedial rectus recessions, and it has the identical dose response, therefore it's quite easy to plan. And lastly, moving on to the most recent and most complex technique, we have bimedial rectus muscle elongation. I'm just gonna briefly explain how it's done. So as we can see here, the medial rectus muscle is divided into 3 longitudinal sections of about 10 to 11 millimeters, with the middle section having about twice the width of the peripheral sections. The peripheral sections are then clamped and cauterized at the predetermined amount of recession between 6.5 and 9 millimeters. Then the middle section is sutured and secured, and then is detached from the insertion point. And the 2 distal portions are attached together to join the central section to form a Y shape. This method had success rates ranging from 70 to 83%, sorry. And Galli et al. Reported that this technique had a greater dose response than the hangback recessions, with about 1 prism diopter per millimeter more. Once again, this technique has no risk of scleral perforation. However, as it is a bit more complex technique, this operation takes twice as much time than any simple recessions, and the procedure can be a learning curve for the surgeon. And now on to some factors that influence the success rates, and most importantly, the impact of the preoperative angle. So research has found a statistically significant relationship between the preoperative angle and successful alignment. And on comparison of patients with angles between 50 to 69 diopters and angles greater than 70 diopters, patients with the larger deviations were estimated to have a higher chance of undercorrection at the 8-week assessment. Therefore, they had fewer chances of developing a consecutive EXO at the final follow-up appointment. This was more specific to the 3 muscle surgery. And in terms of the surgical dose and age of surgery, Minko found that when surgery was performed in younger children, this might have a different dose response compared to older children or adults due to anatomical consideration. But this once again links to the early versus late argument. And just to summarize everything up, the most effective technique seemed to be the bimedial rectus muscle elongation with a 76.5% mean success rate, but this technique was the most complex and the most time consuming. Therefore, not many surgeons might opt for this technique. Very close were the handbag recessions, which was much simpler but very effective. Then we had the botulinum toxin augmented surgery with a mean success rate of 62.3%, which was much higher than the classic bimedial rectus recession. Therefore, once again, it might be preferred. And lastly, we have the 3 muscle surgery, which had the highest rate of overcorrections, and it is limiting us in terms of further surgical management options. Overall, it's really important to communicate with the patient and the families regarding the plan and regarding the aims of the surgery, whether we want to do a stage procedure and see whether we are happy with the cosmesis after 2 muscles, whether we want to have one surgery once and for all, considering 3 or 4 muscle surgery, but also it's really important to explain to them the complexity of infantile isotropias and the likelihood that we will have a residual iso or a late consecutive exo and the need for subsequent surgery at any point in the future, whether that's quite soon postoperatively or 10, 20 years after. So that's it from me. I'll just stop sharing my screen now.
Thank you so much. And Dr. Rajiv Prasad is, I think, just continuing your presentation. Dr. Rajiv, are you there?
Hello.
Hi, sir.
Hi, good afternoon from India.
Good afternoon, very welcome. And I just don't waste more time and just share this, pass the screen to you.
Yeah, thank you so much. I mean, it's such a pleasure to, partnership with BSA, and you guys are doing a wonderful job. Sorry, I'm in a place that I'm stuck. So, there's a little bit of problem and you may get some voice in between, but try to bear with me. Well, coming over to Indian Optometric Association. Indian Optometric Association is the oldest body in the country who is working for the welfare for optometry since last 6 decades. And it has been a great journey. IUA has been, doing quite a bit with Indian government. And very recently, successfully, we got, the National Commission of Allied and Healthcare Professional Act has been confirmed, referring the ISO code of 2267. And as we all know that India currently has the highest number of blind people globally and the second highest number, based on 2015 IAPB statistics, it's 96.20 million. An avoidable visual impairment due to uncorrected refractive error. So we are working, Indian Optometric Association is working very closely with the government, Ministry of Health and Family Welfare to ensure that, we get best of the best to our professionals in the country. We make sure that, whatever is beneficial for the profession, we get the benefits out of it, and government is, coming forward and they have really supported us in best possible way. So the current president of Indian Optometric Association, Dr. Subodh Dikshit, and the entire team, the educational, being led by Prem Kumar Singh sir, who's one of the speaker here, an advisor to VSA. we all are working towards the best what we can do for Indian optometrists, and it's a great the way it is going, and collaboratively it is working very good. Currently, we got a position in Asia Pacific Council as well, and I've been nominated as Vice President of Asia Pacific Council of Optometry. So internationally and nationally, IUA is being recognized as the only statutory body working since quite so many years, and it's just really glad that we are partnershiping with you all, and we'll try to bring out the best of educational opportunities to every single optom in the country. And we look forward for more partnerships on how we can develop more of educational and a way where probably we can collaborate and work to ensure that we get all the best of education and involve and uplift the optometry in India altogether together. Thank you so much.
Thank you, Dr. Rajiv, and thanks again, Joanna, for your lovely presentation. And I would like to introduce our last speaker, Mr. Prem Kumar Singh. Prem sir is a senior faculty in pediatric optometry, orthoptics, and binocular vision, and also head of the Department of Optometry Science at Dr. Schwab Charity Eye Hospital in New Delhi. He was honored with Best Optometrist of the Year award in 2014 for clinical and academic contributions, and Best Oral Paper award at 14th Vision 2020 conference in June. He is the Vice President of Delhi Optometry Association and Education Committee representative of Indian Optometric Association. Prem sir, welcome you again.
Thank you, Johanna, for the detailed introduction. And good evening, everybody. So we had just a presentation from Anton. I'll be taking it forward from Anton has handed. We all know how uncomfortable most of us feel when we have a patient coming to our clinic with a double vision problem. As a routine practice, as a conservative management, it's quite common to see people asking these kind of patients to close their one eye. Just think from a little different prospect. If you as a clinician, unfortunately, either of us has this problem. So we'll really be comfortable, we will be comfortable in keeping our one eye closed, and for how long we can do that to manage the problem. One. Second is about keeping our one eye closed actually keeps us away from our luxury of binocular vision that we have been having over the years. So definitely it will be disturbing our routine life. However, if you see double vision as a problem is not only for the individual that I see, it's entire family which gets affected. Most of the time, because these double vision problems are the result of the acute onset strabismus. As Anton highlighted so well in his presentation, either it could be the neurological reasons. In country like India, we see the blood pressure, blood sugar, uncontrolled blood pressure, blood sugar as becoming a primary cause for having these neurological issues resulting into the acute onset strabismus in many patients that we see, particularly the elderly patients. And then of course the road accidents, which are so common where people lose their binocular vision and start appreciating diplopia because of the acute onset of strabismus. In fact, many more like them, we all face in our clinic in a very in routine way, actually, the way we have been seeing our busy clinics with the kind of population that we have in the country. I'll just start with some emphasis of specific cases just to have sensitivity for all of us, so that we can really understand where we are and how our role as an optometrist is more important in helping these kind of patients. So just think of a girl at this age, where while clicking her picture, she gets one eye closed or smaller, just because she gets double vision or photophobia because she had an intermittent exotropia that results into closing her one eye. She's not going to be comfortable ever because of this problem. An elderly person of around 45 or 50 years of age whose whole family actually, the earnings of his is helping in running the whole entire family. And suddenly if he mets up some accident, or he results into this double vision problem of acute onset diplopia, how the entire family is going to get affected. Or a student, maybe class 10th or 12th, or in a higher class, if he plans to undergo surgery at this age for his strabismus, which he was having since early childhood or since infant, and if he lands up for an overcorrection, which results into seeing a double vision, then what actually you will be looking for? Because you have given him a hope of operating him and making his eyes straight. But a small overcorrection can make him to see that double vision issues. Or we miss actually to look for the ARC component in him, and we ended up we planned the surgery for the actual measurement, and we had that because of abnormal retinal correspondence patient is seeing now, double in spite having the straight eyes after the surgery. Or even a professional at this age, where in fact he thinks, I remember this guy, he was an astronaut, and he was planning to switch his profession because he was not able to appreciate the depth because of the intermittent squint that he was having in his eyes. And this patient I'm never able to forget actually. He's a teacher by profession. So he's a teacher by profession. I've been following up for more than 10 years now, and he keeps almost every second or third year to get his prisms changed. It was when he tells his complete history, says for 3 years he has never been to a movie with the family because he used to see the 2 screens, and which he hasn't left any place in Delhi around where he has not gone to get the solution for his problem. And when we gave him a prisms in his glass to relieve his diplopia, which was existing for such a long period, he actually is not able to. Whenever he enters my clinic, he comes with the hands, with both the hands together. He says, "Sir, you are the one who has actually given my life back." It's that kind of like thankfulness he always offers whenever he enters the clinic. So this is what actually, for we as a clinicians, to many patients that we happen to see, and with this small learnings of ours, or with this small extra efforts that we can take for these kind of patients, and actually help them in regaining their life back or improving their life for the future if we are dealing with the smaller children. So what kind of cases we usually see? Even if it's very common that whenever we see this patient in my Prism clinic and binocular vision therapy clinic, patient commonly come after the cataract surgery or a retina surgery. So as a surgeon, one will be very happy when patient reads 6.6 or 6.5 after the surgery. But if the next moment patient says, "Sir, doctor, I'm seeing double." So all that happiness of 6.6 actually ends at that moment only, and then you start thinking a little differently. See, we all understand the possibilities of complication during a surgery, but yes, we need to understand how can actually we help these patients again in maintaining their happiness with the vision what they have got, and then overcoming their double vision problem that they have had, which is very common to have usually after cataract surgeries. Even many times the plants that we plant now, glaucoma surgeries, buckling actually yes causes. And I've seen more common in post retina surgeries, because over the period, if there was no vision in that eye or less vision in one eye, that results into the sensory tropias. And since patient was not having vision or poor vision in that eye, they never complain of double before they get operated. And once they undergo the surgery, they start seeing better with that eye, and then immediately they start complaining of double, because by the time eye had a drift outside, and patient is not able to bring the eyes together to fuse again. So these are the patients immediately you can really help them with the help of your prisms and therapies. Acute onset palsies, as Anton was highlighting, it's very common to see in our clinic that we see patient coming with double vision problem, coming with closing one eye to manage it, or having different kind of abnormal head postures. So these patients, keeping one eye closed, yes, you help them in relieving the symptoms, but you're not actually encouraging to learn to fuse the 2 eyes again. So somewhere, we need to understand that how to again make the patient to learn to fuse, or the kind of problem that they have had. Of course, etiology needs to be worked well, whatever has been the cause behind it, and simultaneously to help the patient again to regain their binocularity. Squint surgical cases, particularly at the elderly age, because even now in the country we see people still have that myth about it that not to get the squint operated, or at the early age. And later is when they are at the age of marriage, on when they start realizing they're not able to fitting well into the social circle, or they're not getting good responses from their friends and others, then they start thinking about getting it corrected. So you definitely offer them the services, whatever the best you can do. And many times they'll end up, if they have developed the ARC or they have the overcorrections of the surgery, they may end up with the double vision problems. So I know about this girl who had a surgery and she was quite straight, but there was little overcorrection in her case. And then we had to give her a prisms with the Vergence exercises. And through that, we could gradually wean off her prism and make her to fuse again. Diplopia after road accidental, the RTAs is very common because people are not in the habit of using helmets, particularly in motorbikes. And we see very commonly these kind of patients coming up and reporting about the double vision problem. Even in the at the elderly age, you see very common these kind of patients coming to our clinics. In fact, this was a paper I was seeing that where almost 150 patients had a double vision problem after the cataract surgery. And out of these all patients, 64% actually got simply improved with the help of prisms, which were given to either the Fresnel prisms or the prisms, the glasses we call ground prisms. And then very few percent is required intervention in terms of surgery. In fact, if you ask me in my clinic, these acute onset strabismus cases, particularly the one who complain about diplopia, they are the best to treat. And they get very, in fact, most of them you will be able to help until unless there's not a limitation beyond the primary position. You can help them in getting their binocular vision back with the help of prisms and Vergence exercises. And it's best to have a diplopia to help them do, because if somebody has a squint and they have developed suppression, that becomes more challenging for you to bring them back for binocularity. I remember our late Dr. Kalam, the former president of India, he in fact had a double vision problem after his cataract surgery. In fact, it was same. He had a decompensated phoria resulting into tropia and having a double vision problem, more for the near. And for him, it was so difficult to manage at that time because he was fond of reading and writing. So he was given prisms, I remember. We tried to even encourage him to do some Vergence exercises so that we can gradually wean up from the prisms, but he wasn't really good compliant in that way. So still, so till his last days, he continued reading with the help of prism glass, and which could help him. After, as I said, after the retina surgeries, after secondary IOLs, SF IOLs and all, you see patient usually coming and complaining because for such a long period, they were not having the straight eye, the eye which was not seeing, it drifted out, and then they suddenly land up with the double vision problem. So very easily, in fact, within second or third sitting of yours, when you give them prisms, they start learn to fuse, and you're able to remove the prisms in these patients, and you can keep them on Vergence exercises for some time without prisms, and then you can switch gradually to the home therapies, home exercises to maintain the results so that it doesn't drift out. I remember this Dr. Bilal, who had the retina surgery, had a double vision problem, and I think within 2 weeks of his prism and vision therapy exercise, he was able to fuse well. A lot of patients after strabismus surgery that we happen to see, because he was busy clinic in our place for strabismus, and a lot of surgeries are done, but yes, we'll end up having these consecutives and double vision problems, or even the residuals with exotropias, where again with the help of prisms and or over minus glasses, you can help them learn, because it's not a large deviation now, it's a small deviation which is residual there, and they had usually they are the intermittent exotropic cases which gradually over the period become the constant tropias, so they have a fusion potential. So by bringing the most maybe further closer with the help of prisms or over minus glasses, you make them learn to fuse, and gradually you can remove the prisms and the over minus glasses, and then they learn to control it very well. This is a girl I remember, for 9 years female, who complained of double vision after this squint surgery, was operated for intermittent exotropia. These were the measurements. As you can see, post surgery, she had a 30 ET in primary gaze. She had a pattern, more ET in the up gaze and less in the down gaze, with the double vision problem. So the diagnosis of consecutive esotropia with A pattern. And to her, we planned the prisms, because if you see her down gaze was around 12. So we didn't go with a 30 prism, we go with the 12. In these kind of patients, I prefer personally using the ground prisms over the Fresnel prisms, because many times Fresnel blurs the vision in an eye. So encouraging fusion becomes a little more challenging. So if you go for a ground glass prism, because that doesn't affect the vision much, So you can encourage the fusion more in the and more easily in those kind of patients. So I prefer going for minimum prism, which can encourage the fusion, and then you start them on the divergence exercises, and gradually you can start reducing the prisms or completely wean off the prisms. So in her case, I remember we started with the less prism as a ground glass prism, and then we started therapies with the chin up a bit, and then gradually we encouraged her to keep the head straight, and then she was able to fuse well over the time, and she developed almost 60 seconds of stereopsis with uncrossed diplopia on WFDT, because still there was a phoria component present, and Bagolini because there's a de-suturing test, on that she was fused very well. In elderly patients, as I said earlier, the prism adaptation becomes very important before we plan a surgery for these kind of patients. Because if you see this patient was a large exotropia of around 55, I remember, as you can see here, this is after dissociating, because we gave a relieving prisms to him, frenal prism, as you can see this eye. Now he's not controlling it. Usually these patients who are controlling such a large exotropia, you'll find they complain of blurring of vision, or when you just do a dry refraction, you will find that they have a over minus correction that they accept, and in cyclorefraction you may not find that kind of myopic shift. That's because they're trying to accommodate more to get accommodative convergence, and that lends up leading to the more myopia in these patients. So you can help them in relaxing before you plan a surgery, so that otherwise they have more chances to. If you can mute the people, Abhishek. Sapnish, if you can just look into that. So these kind of patients, you can really help them first to relax, have the maximum measurement, and then plan a surgery. So after surgery, you can see he was completely straight. Otherwise, many times if you go for surgery at this stage, because they have been using the accommodative convergence so well, even if you plan a surgery, he may be in the habit of using it, continuing it, and that may lead to the consecutive esotropia. So many times it becomes important to relax them. Here you can take help either of a temporary patch on one eye, or you can even keep a relieving prism so that it helps in dissociating the deviation, and then you plan a surgery. So overall, if we see, even there are the papers, the people have talked a lot about this binocular vision therapy, orthoptics, the pre-surgery measurements, post-surgery interventions from optometrists, where the people talk about it, they highlight about it. It's really important to have prism adaptation test in elderly patient before surgery. And overall, the orthoptic services are considered to be really useful before as well as the after surgery to really optimize the results of your strabismus surgery. So if you see here a patient with the abnormal head posture, in the presence of nystagmus, so you can decide a prism easily. You can see the patient is trying to keep the eyes towards the lever version. And if both eyes are fixing, patient is not having strabismus, you can divide the prism if surgeon is not planning for a surgery. So you can divide the prism between two eyes, or if there's a squint in one eye, still having abnormal head posture, just to keep the eyes in the null zone, you can plan a prism over the fixating eye. So then you can help the patient in making the head straight. So how does the prism work? If you just take the two eyes as straight, where you see there's a bifoveal fixation. And if you place a base out prism here, so we all understand the property of a prism. It deviates the rays towards the base. So since the direction of rays which were coming from object to the fovea has changed now, and they're falling on a different part of retina. So since patient is fixating with both the eyes, to remain fixating with both the eyes, maintain a single vision, not seeing double, what the patient will do, he'll try to turn the eye inward so that the fovea goes in the direction where the rays are falling on the retina now. So again, the rays start falling on the fovea. And this keeps happening till you start increasing the power of prism, and patient able to maintain the convergence. So that help you in measuring the patient's ability to converge both the eyes. This is how it works. So as you can see here, with the prism, gradually patient started fusing with the fovea, and then he's able to again maintain the fixation over the target, seeing the target as single. If you see patient with the strabismus, as you can see, there's a patient with the ET, and the rays are falling on the nasal side. Patient eye is having inward movement. So this is the fovea here. So one is you place the prism in, either you occlude this side, right? So once you occlude this side, patient will fixate with the fovea, which is fine. So how does the prism work in these cases? If you're placing a prism on a squinting eye, it will work differently. If you're placing a prism on the fixating eye, it will work differently. So we placed over the squinting eye, then again it changed the direction of the rays towards the fovea. So if you have a smaller prism, it will deviate less. Greater prism, it will deviate more. And when you get appropriate prism, then rays start falling on the fovea, and when you try to occlude this, I will not see any movement. This is how we neutralize the amount of deviation we call diagnostic prism. So you reach a conclusion how much is the amount of deviation. This is how it works. Or if you place a prism over the fixating eye, so then what will happen? You're placing a prism in front of fixating eye, as we saw earlier. Now it will show a different effect. Rays deviated towards this side, temporal side from the prism. So patient will move the eye again. He'll move the eye inward, this fixating eye, to remain fixating over the target until he start fixating with the fovea again. But in the response to this, the squinting eye will show outward movement. That's because of the Harring's law. So you keep increasing the power of prism until you find the rays are fixating, falling on the fovea, and eye appears to be straight, and where you can just have a confirmation again with the help of cover test. If there is no movement, that means that's the correct value for your diagnostic or relieving prism. So this is how these prisms, you reach this prism behave differently for your diagnostic as well as for a therapeutic purpose. So in diagnostic prism, actually what's happening, you're reducing the work, which help to move the image to the direction where the eye is seeing from. So you're moving the eye, the deviating eye towards that direction. This is how you have help the patient in relieving the symptoms immediately by giving these relieving prism, or to call diagnostic prism or compensatory prism. So all three prisms have a same base. But if it's called a therapeutic prism, there you're trying to develop the strength in the muscles, or develop the control, the motor control for the patients. So that works a little differently, where you're increasing more work for the eye to remain fixating with the two eyes to fuse. And that helps in improving your sensory perception as well as the motor control, where we work on improving the vergence. So, you know, we are very well aware about these different kind of prisms. This is the Fresnel prism, small sheet. Then you have a ground prisms that optical people make in the glasses. Many times you don't need this trial prisms. If somebody has this to trial, particularly for higher powers, it's really helpful in a strabismus clinic. Otherwise, your trial set itself have these prisms, small power prisms, which you can use, or even you can use the prism bars for your patient for diagnostic as well as for a therapeutic purpose. I prefer giving 6 to 8 prisms, easily 8 prisms in one eye. I can give prisms in the glass itself. If I require more than that, then I take help of these Fresnel sheets, Fresnel prisms. So for binocular vergence, to improve the vergence, convergence, and divergence, you take help of prisms. So we're giving base out prisms to increase the convergence, and base into help in relaxing the patient or to improve the divergence. So this is how we see earlier it works. You're changing direction of the rays coming from the object towards a different point, and then patient moves the eye, moves inward, and it keeps moving till you start increasing the prism and a break point comes where he's not able to further continue moving the eye and refixate in the new direction. And then you repeat the process. So that helps in improving the vergence. So if you see the patient of DRS, you can see there's a face turn towards the left side. That means patient is preferring to keep the eye on the right side, and you can just try a prism. So you try prism in one eye until unless you find the head is straight. If it is overcorrection, you can gradually reduce the prism. See, again, he has moved the eye toward the face to the left side and trying to move the eyes towards the right side. So no strabismus, but there is a limitation because of DRS that you can see, and patient is trying to keep the eyes away from that limited area to remain fixating with both the eyes, and that's where you can help the patient correcting his abnormal head posture by giving prisms in your glasses. Sometimes along with the horizontal deviation, one may require to give the vertical prisms. So either it could be like in one eye we give a horizontal prism and other eye we give a vertical prism, or you can take help of compounding of prisms, where you can give in the same eye you can give horizontal as well as the vertical prisms. So I've tried to take a calculation here. If you see there's a condition of exotropia, suppose XT is there, with right hypertropia R over L. So you'll be requiring base in prism for this patient along with the base down prism. Base in for XT, and since it is R over L, So base down in front of the hyper eye or base up in front of the hypo eye. So if you're giving over the hyper eye, which is the right eye, so suppose you require horizontal prism of 8. 8, this I'm talking about right eye, so base in 8 right eye and around 6 for vertical prism as base down. So you can give both these powers. You can give a single prism which can give both the effects, a base in effect as of 8 prism diopters and base down effect of 6 prism diopters. By calculating, we all have read this Pythagoras theorem in our class 10th, where you can just take help of this. There are in fact tables available on Google. You can take help of Google as well, Google University, where you can get these calculations easily. Otherwise, you can do if somebody has been good in maths. So if you just calculate a Pythagoras theorem, 8 square plus, vertical, the perpendicular and base, square of perpendicular plus square of base is equal to the hypotenuse. So we calculate this with square root of 100, because 8 8s are 64 and 6 6 are 36, so 100. So square root of 100 will be 10. So around prism of 10, you can try easily here with a new direction, not base in or base down. If you choose this angle, which you can calculate with a D. In fact, if you're not good in this calculation, you can just simply take a millimeter scale, take a plain paper, make a draft, make any chart. Each unit counting for 1 prism diopter, make equal marks of 8 and 6 on this side, draw a diagonal, measure the length of this diagonal. It will be a resultant power of your prism. And this will be the direction. With the help of D, you can measure. So around at this angle, which is around 150, 160, you can take a prism of around 10 or 8, give a trial to it where patient sees the single, which will give you base in effect as well as the base down effect. This is how we can calculate. Or suppose there's a patient with XT with L over R. So exotropia with L over R. Left is hyper now here. So we'll be requiring a prism of right base in and base up over the right eye, because it's a right eye is a hypo eye now. So how will decide the prism base? So 8 base in, 6 base up, then a resultant of 10 as we calculated earlier. And how will decide the prism direction? So it should be somewhere here. So somewhere at 30 or 40 with a prism of 10, you can give a trial frame, and then you will get to know where patient feels comfortable. And that could be a final power for prescribing the prism in the glasses. So Fresnel prism, I have a small video here. This is how it's fitted. The people who have not seen it, they may find it interesting. So once you make the measurements, you come to know the final power of prism required for your patient. You can give a walk-in trial with your trial frame, trial lens prism, Fresnel prism. He was complaining eye ka zyada number just because he was not seeing very clearly with that eye. So this is the sheet of prism. It's very thin. Suppose you require a power of around 20 or 30 or 40. It's not possible to have that thick glass in the frame. A patient may not be comfortable. So you can just give a thin sheet. So any power beyond 10, I prefer going for a Fresnel prism. So you cut to the shape of this spectacle. Just give a trial to it. Hope it's fitting well. And then you can just take help of turning tab auto, where you just remove it again and replace it. So you need to just ensure that there should not be air bubbles. Giving running tab water, place it again, gently press it so that there are no air bubbles, so that it adheres properly. And then you can just wipe it off all the droplets with the help of a soft tissue. And in case you see any water drop, the air bubbles, you can just gently press so that it goes away towards the periphery. So just if we can see here, suppose this is a patient who has abnormal head posture of chin up, and there is in fact face turned to the left side. So can you try prisms in this patient? So I'll decide the direction of the prisms. So patient is trying to pull keep the eyes in the down gaze actually. So anything which can help in bringing the eyes off its own, down off of its own, that will like overcome the patient and from the demand of bringing the eyes down, because the prism will help him in bringing the eyes down. So you can plan a base up prism in front of the right eye, or whichever is the fixating eye, or both eyes are fixated, you can divide the prism. So automatically eyes will come down then patient will not be requiring to adopt the abnormal head posture unless there is not a limitation beyond that point. So ocular movements again plays an important role to understand before we decide for a prism. Suppose this patient who is having an ET, trying to keep the eyes in the right gaze by keeping the face on the left side. So you can decide a prism again. So either you can have a base out prism here or a base in prism here. Since it's the ET, so base out prism will be preferred. The patient is having diplopia, so you can give a base out prism on this side. Could be, it looks to be a little larger angle, so you can take help of Fresnel prism. So patient trying to turn the face to the right side to push the eyes away from the right gaze, because this patient, I remember, had a right lateral rectus palsy. So you can plan a prism in this patient easily. You can just correct that deviation of ET which he's having because of right lateral rectus palsy. So you can plan a base out prism in front of right eye, which will help him overcoming his double vision problem and will help him automatically correcting the head posture. And then you can keep the patient on the vergence exercises to improve that, so that gradually you can wean off the prism. Here in this patient, you see, again, eyes out, you can see very clearly. So you can plan a base in prism for him to encourage fusion. And once the eyes comes close, try keeping it undercorrected. And that's what actually everybody advocates. Because if you give a full prism, then patient relaxes completely. Will not be putting in efforts. The vergence efforts will not be there, and there are more chances the deviation may be more. So it's better to undercorrect it around 1/3 of the total power that you're getting in your measurement, and then you can encourage fusion because images are much closer now, and patient will be able to control it. So combinedly, a vision therapy and surgery approach actually helps in making the ultimate results of your strabismus much more optimal and much more stable. Because most of the time we operate the patient, the eyes have a tendency of drifting again to the original position if the fusion is not developed, if motor fusion and sensitive aspects are not taken care of. So if sensitive fusion develops and patient is able to improve with the motor vergence part, then they are able to sustain with the outcome that you get in the surgeries. So that's where, because the sensitive fusion acts as a glue in keeping the two eyes together to be in the use. So ultimately, the surgery and the sensory fusion development at Binocular Vision Therapy Clinic with the help of prism glasses and vergence exercises help you in optimizing the overall results of a strabismic patient and making the patient happy and of course the clinicians happy. So a combination of a prism or optic treatment can really restore fusion in the patients, and your experience as well as the experience of patient about your services could be really appreciating. And we as a clinicians should feel responsible and feel more like encouraged to help these kind of patients, not just as a patient, just to help somebody who has entered your door for a service. And once you can do justifying job, that definitely gives a satisfaction to you as well as help in boosting of your overall practice and of course the satisfaction for your patients. Thank you. This is a vision therapy clinic where most of these equipment we even have for the home therapies also. Thank you, and thanks to all my patients who help me every day learning from them and using my experiences of learning over the other patient to help them. Thank you.
Thank you, sir, so much. And we've got a question for you. Somebody asked, how much power overcorrect in exodeviation cases?
Okay, so overcorrection, usually the surgeons plan for little overcorrection and then they for around 10 prism diopters, and which they expect it should last within a week to 10 days after the overcorrection without causing any diplopia issues. It may be initial diplopia immediately after surgery if there's overcorrection, but it should be able to, the brain should be able to team the two eyes and diplopia disappears and patient is able to maintain the straight eyes. But there are patients who are not able to achieve that. So that's where if they put in our protocol, if after a month of surgery, patient is still persisting with the consecutives, could be even a small angle of 5 prism or even less, resulting into a diplopia and disturbing the patient, then we take help of prisms and the vergence exercises to realign the two eyes and help them in avoiding diplopia and maintaining the straight eyes.
And also another question about how much diopter pinhole can increase the vision. I think she means line in visual acuity, right? That's more accurate than diopter anyway.
Okay. Okay. This, I think it's a good question. It all depends upon the potential of vision one is having. So it's just a test. We all learn it at school time. In fact, we teach our students that if somebody comes to your clinic with the subnormal vision, to try it with a pinhole vision. I'm sure as you get experience, you're not doing that because you try preferring saving time and just do a retinoscopic flash, put a lens and get a 6/6 for a patient. But yes, many times you're not knowing whether the patient visual acuity is going to improve with the spectacle correction. The lenses you're planning, possible, there's a potential to improve with the spectacle correction. Then we do this test. And if the vision improves with the help of pinhole, that means patient can be corrected with the help of spectacle correction.
And Sabahat asked what to do in case of dissociation vertical deviation.
Yep. That's a good question. In fact, even today I get these debates with my surgeons. They say your vergence may not work for your vertical. Actually, if you see vergence control we're talking about is the motor control. So we all, as a human, have this vertical vergence as well as the horizontal vergence power to keep the eyes under control. So many times we have seen, even a small deviation of vertical will not let you fuse. So, or there's a large deviation of, even as we see in those patients, somebody having a XT of around 50, they can still converge. They can induce the accommodative convergence and then they can fuse. Somebody with a 4% diopter vertical, he may not be able to fuse. So usually if there is a small angle deviation, we plant prisms. In my clinic, what I do, even the horizontal aesthetic with the small vertical, I prefer giving vertical prism and may not give for horizontal. And with that small vertical correction, we'll keep down vergence exercises and gradually we find as the fusion, the motor control improves, you will be able to even remove the gradual prism, the vertical prism gradually.
Thank you for your comprehensive answer. Thomas has asked, thank you for a very nice presentation, but how will you manage and patient with exotropia with horizontal nystagmus?
Okay, so it's a horizontal nystagmus is there with the exotropia. So again, as I said earlier, if that nystagmus is making the patient to adopt the abnormal head posture, okay, your management plan is going to be different. If it is just an exotropia and there's null zone is in the primary position in spite of that exotropia, and patient is not concerned, but patient is not having abnormal head posture, then you can plan the exotropia surgery as you have been doing for other patients. But if it's a null zone, then you actually have to see which direction you are going to move the eye after your squint surgery. So many times, if it is opposite, even in the presence of exotropia, having a null zone in some other gaze resulting into the abnormal head posture, you may not be able to plan the surgery for those patients to correct the abnormal head posture. And if you'll end up in doing the surgery just for exotropia and patient was having a null zone in primary gaze, you may find excellent results. But if it's opposite the null zone, then you may find that abnormal head posture may be even further increased after your exotropia surgery. So have to be a little careful in those patients that if exotropic eye, suppose the eye is out, if I just go more specifically, suppose right eye is out and patient is preferring to keep the eye in the right gaze, the null zone is in the right gaze, you can directly, you may be really scared to plan a surgery because if you go for a basin, you can plan a surgery easily for this patient. But if the abnormal posture is opposite to the left side, right side, and patient is preferring to keep on the left side, then planning a surgery for exotropia may result into more abnormal head posture.
All right. And Janani asked, a strong accommodative spasm with pseudomyopia more than -6 diopter spherical post-dilatation shows normal. Whether vision therapy is helpful for the adult and how to overcome this?
Yeah. In fact, I'll say even before COVID, we were getting few cases reporting with these kind of issues. After COVID, in fact, we are seeing more cases because so we're getting acute onset esotropia resulting into this double vision issues and having this spasm of accommodation over the pseudomyopia. So in our protocols, we first try to relax their accommodation after doing all those clinical assessments. And there we take help of the HOMITE. So first we relax the accommodation. Once they relax, they learn to relax that accommodation. Then gradually, under the cover of our accommodation relaxing exercises, we start reducing the dose of HOMITE. Sometimes even if the ESO is more for near and it's not much for distance, you can take help of bifocal to keep the patient relaxed for near, or even just by gradually stopping your HOMITE, the cycler drop, you can start simultaneously the therapies for your patient in a vision therapy, where I take help of plus LensRec, helping them learn to relax the accommodation, and even along with the vergence, so that you have developing good teaming of the two eyes, and you can help these patients completely getting. If it's really required, patient is not able to relax completely, you can even take help of prisms initially to align the two eyes, and then you can keep them on vergence exercise and accommodation relaxation exercises, and you can help them in gradually coming out of that problem.
Okay.
Most of the time, these patients, you find they have a psychological reason. Yeah.
Okay.
So detailed investigation about psychological reasons become important in these patients. Yeah.
All right. And Dr. Dimpai asked, how to manage patient if intraocular nerve is damaged?
Sorry, I missed it. Intraocular?
How to manage a patient if their intraocular nerve is damaged? I mean,
intraocular nerve is damaged. In relation to what, like, or you want to get the nerve repaired, or you want to say something else? I think, can the question more specific?
Yes, I think the question.
If vision is not good in that eye, okay. If I'm getting it correctly, maybe intraocular nerve is damaged. The vision may not be really good in that eye. In fact, we've happened to face these kind of patients where the vision is not really good in the affected eye because of whatever reasons. And if there is a drift of exo, and patient may complain of double vision issues. So even one may say it's hardly 2/60 vision. Why patient is complaining of double vision? But patient do have problems, even with that blurred image of that eye, seeing that as double. So again, you can try prisms to relieve their symptoms. Yeah.
Okay. And Rohit has asked how to manage patient with bilateral superior oblique palsy.
Okay. So of course, yeah. Usually in bilateral superior oblique palsy, you'll find the horizontal deviation is not much unless this bilateral superior oblique palsy is not asymmetric. So usually in the primary position, you don't get much deviation. These are the gazes where you find the opposite higher deviation. Maybe in the right gaze, you will find, because left superior oblique is affected, you'll find left eye going up. And in the left gaze, you'll find right guy going up. So in both the cases, we plan inferior oblique recession as a surgery to help these patients. And if there is some residual after the surgery, this, of course, we take help of, again, same, our prisms and vergence key. My broadcasting, my favorite exercise with the help of prisms.
Okay. And Mahima asked, thank you, sir, for a wonderful session. What should be the first line of treatment in case of decompensating phoria?
Yeah. This actually very commonly seen in, I'm sure, any kind of establishment practice, decompensated phoria resulting into tropia, landing up to the double vision problems. So decompensated phoria with suppression, I'll say difficult. Decompensated phoria having a diplopia, easiest to treat. So you can again go for same partial prism to encourage fusion, and then keeping them on fusional vergence exercises, encourage more and more positive vergence, and gradually bring the patient off. Don't keep the patient for too long on prisms. So gradually either start reducing the prisms or completely weaning off the prism if it is not too high. And then you'll find the patient learn to control. All these patients with the cataract surgeries, if they had denser cataract in one eye for a longer duration, you may find resulting into decompensated phoria. The RD surgery patient, because many times to get a surgery date for RD takes a little longer, being an overall procedure a little longer, so date goes only for a month or two, even in our institute. So they all have a tendency of decompensating into tropia. So all these patients, once they get vision back, they result into the double vision problem. I can say this with you can take my words that within 3 to 4 days, You give them a partial prism along with the Vergennes exercise, you should be able to remove the prisms from those patients and gradually just keep them on maintenance Vergennes exercises, and they does really well.
Thank you. And Mr. Anil has asked, Prem sir, can you explain about the alternate exo or iso deviation? I'm always confused, which I have correct with prism mostly happen when patients' eyesight are equal.
Yep. So again, I say the same thing. Prism, prism, prism. Prism means having a double vision. If it is alternating, you can decide either of the eye. Patient will be encouraged for fusion. Okay. If you need to give a little higher prism, as I said, you can give easily 8 diopter in glasses, ground prism, in your spectacle only in one eye. So if you need little more than 8, you can divide that. If you need overall 12, you can divide 6 in the 2 eyes. If you need 16, you can divide 8 in the 2 eyes. If somebody requires more than that, then you can take help of Fresnel prisms, but then keep Fresnel prism only in one eye, because that will blur. If you go for both the eyes Fresnel prism, one, the cost, second, vision will get affected. So at least we can see clearly with one eye, because almost 1 to 1.5 line vision gets blurred with the Fresnel immediately, and then over the time, as it gets decolored as well as has some scratches and the dust, it may further affect the vision more. So prefer going for ground prisms if it is coming in the measurement range. If not, please take off Fresnel prisms over one eye, and then, but if it is a diplopia, again I'll say, then you will find results. The patient is suppressing, having alternate switching between the 2 eyes. I don't know what you're trying to get in that patient, but yes, I think you should plan immediately for a surgery.
Thank you so much, sir. I think we've done with the question. And if it's possible, we have Joanna and Anton also on the screen. Mr. Anton, are you still there?
Yes, I'm here.
All
Go
right.
ahead.
There's a question from Amrita that can we differentiate long-standing and recent onset by Hess chart?
Hess chart will help you to quantify the paralysis or paresis, but long-standing or short-term paralytic squint is usually confirmed with the history. It's usually confirmed with the history. Okay, so the Hess chart will just quantify. Okay,
Yeah.
so yeah. Prem, if you want to add anything to that, go ahead.
Yeah. Even in the long-term cases, yeah, many times they are really helpful if you go for a hash charting. In fact, I remember Anton highlighted in his presentation also that usually these patients start moving towards the concomitancy over the period. So you may not see exactly the muscle cycles correlating with your contractures, overactions, or second initial policy. But yes, many times you can just compare the two charts until it's really not too much. Even if there's some kind of incompetency remaining, and that you can even come to know with your primary and secondary division when you're doing a clinical examination. If that difference is there, then you may find the difference in your Hess chart degrees as well, and then you can see the overall displacement of the chart, how much it is there. You may not get a C-clip, but chart displacement will be there depending upon the amount of deviation patient is having. Does that answer the question? I don't know.
All right, thank you.
We can quantify the area.
And Joanna, I assume you are just practicing in Greece, if I'm not mistaken. So what is your routine, for just taking care of patient post orthoptic surgery?
We tend to see the patient 1 week post-operatively to see the initial measurements. Obviously, within the first 2 months, we keep closer monitoring until the eye is reaching its final position. And then we just monitor that the patient is healing well, there's no any scarring, any post-operative diplopia, even though we haven't had any so far, and that they're doing their drops regime correctly.
And Joanna, I assume you are just practicing in Greece, if I'm not mistaken. So what is your routine, for just taking care of patient post orthoptic surgery? Amazing. Thank you so much, because it's the first time we are having optometrists from Greece. So thank you so much to you, our amazing guest, and to our audience. And also we have Mr. Amod Gokte, the founder of Bharati Vidyapith School of Optometry in Pune with us. It's really an honor to have Sir here today with us. So if you guys want to add anything, just go forward. Otherwise, we have to just end the session. No?
Beta, I think the session has been going on very well. I really appreciated the first session by Anton, and also I could not attend the second session so much. But yeah, I could hear when Prem was giving the presentation. I joined in quietly a few minutes later. I think the overall session went on very nice. It was, for me, it was a brush up of the basics after spending a lot of time in contact lens industry and now coming back into education. It was a brush up for my basics. So very nice session. Thank you, all of you.
Thank you so much, sir. Have a great time, everybody in the globe you are.
Thank you.
Bye.
Thank you
Bye.
very much. Bye, everyone.
Bye.